Hi, okay, my name is Tara. I'm one of the pharmacists at Vic Square Pharmacy, and we are the pharmacy that dispenses the medications for the Youth in Eagle's Nest program. So today in my presentation, I am going to discuss with you several classes of medications, side effects that go along with those medications, and a little bit as to what those medications will treat. After that, we then go over the medication administration policy, which I'm sure you are all aware of, that you have to follow when dispensing medications to youth in this program. So please, if you have any questions, make sure to ask them throughout. It's a pretty informal lecture, so just ask away. All right. So the way this slideshow is set up, I have different classes of medications, and then I list the names of the separate drugs that fall into that class, then the side effects, and any other notes that I want to share with you. So the first class of drugs that we're going to discuss are antidepressants. They are used to treat depression. That's their first line indication, but just to make you aware, just because a patient is on one of these medications doesn't mean they have depression. There are many second indications that a medication might have, or even off-label uses. So just because somebody might be taking an antidepressant doesn't mean that we're treating depression. In depression, though, there are several thoughts as to why it's caused. Some believe that there is a genetic link, so if you have a family member that has depression, then you might be at a greater risk of having it yourself. There's also a thought that there's an imbalance in chemicals in our brain, and that's why patients have depression. So there are several different thoughts as to why patients do become depressed, and I think it's more of a mix among those thoughts as to why patients do suffer from depression. So the first class of drugs are tricyclic antidepressants. They are an older class of medication, and they're not used generally as first-line treatment for depression anymore. So how these medications work, they increase two chemicals in our brain, serotonin and norepinephrine, and after several weeks of use, the medications will be working properly, and they'll be increasing the levels of those chemicals, and patients will have relief from their depressive symptoms. Medications in the class of tricyclic antidepressants include amitriptyline, clomipramine, dizipramine, imipramine, nortriptyline, and trimipramine. Like I said, they are used in depression at higher doses, but we also see them at lower doses for other conditions. For example, imipramine at 10 milligrams can be used for sleeping, like if patients have insomnia. It can also be used for bladder control. So just because a patient might be on one of these doesn't mean it's for depression, especially at certain doses. The same with amitriptyline. If you see it, at 10, 20 milligrams, that's often for sleep, not for depression. So these medications will increase serotonin and norepinephrine, but they also affect other chemicals and receptors in our bodies, and so that's why they have quite a few side effects with them. So a list of side effects is below there. It includes dry mouth, blurred vision, constipation, urinary retention, tachycardia, which is an increase in heart rate, sedation, weight gain, orthostasis, which is a drop in blood pressure when you're going from a lying down position to standing upright, lowered seizure threshold, and sexual dysfunction. And so there's tons of different side effects, and it's because they act on several different receptors in our body, not just increasing those two chemicals that we want for treating depression. Another note about these medications is that you should avoid them in patients that are extremely suicidal, because you can overdose in them. If you take too much, it will be fatal. Also, you would want to avoid them in patients that have cardiovascular conditions, so maybe some heart conditions, as well as closed angle glaucoma, because they can increase the adverse effects if you're diagnosed with closed angle glaucoma. So the next class of antidepressants are the selective serotonin reuptake inhibitors, also known as SSRIs. These are more first-line medications now for treating depression, and that's for several different reasons. Number one, is that when you start one of these medications, you're starting at a therapeutic dose. With the tricyclic antidepressants, doctors will titrate them up from a very low dose to a higher dose, and that's to avoid side effects because of all the side effects that are that go along with tricyclic antidepressants. These ones, when you start them off at, say, 20 milligrams, which is a fairly low dose of, say, Paxil, it's already very effective at that dose. So that's one good thing about these ones. The other thing about them is that they do not have the same overdose potential. So if you were to take a whole bunch of, say, Paxil, it would be hard to overdose on it. However, if you were to combine it with other drugs and alcohol, it still could potentially be fatal, but on its own, the overdose potential is not the same. And the other thing that is better about them is that their side effects tend to be more manageable than, say, tricyclic antidepressants. But they do have their same, like they do have a list of side effects as well, including nausea, dry mouth. They often cause a decrease in appetite or even leading to potential anorexia, so that's something to watch out, especially because depressed patients often have a poor appetite anyway. They also can cause some drowsiness, sexual dysfunction, and increased risk of GI bleeds, which is a stomach bleed. In young patients, we're not really concerned, but say in an elderly patient that was on maybe warfarin, which already increases your risk of a bleed, that would be more of a concern. These medications as well have other indications, not just depression. Paxil, for one, has many different indications. It's used in anxiety disorders, post-traumatic stress disorder, lots of different things. So they're not just used in depression. And as the name indicates, the main way that it acts is by increasing specifically serotonin in our brains. Drugs in this class include citalopram, escitalopram, paroxetine, fluoxetine, fluvoxamine, and sertraline. So. Then we're moving on to a class of medications that act similar to tricyclic antidepressants in that they increase both serotonin and norepinephrine, but they don't affect all the other chemicals or other receptors that the tricyclics do, so they don't have as many side effects. The drugs in this class include venlafaxine, which goes by the brand name of Effexor, and duloxetine, which is Cymbalta. So they increase serotonin and norepinephrine, and they do have some side effects, but the list is quite a bit shorter than the tricyclics. Side effects include nausea, potential headache, drowsiness, dry mouth, dizziness, sexual dysfunction, and even increased diastolic blood pressure. So the doctor, if a patient is on one of these medications, might monitor their blood pressure at each visit. So now we have 3 antidepressants that are kind of on their own class, their own class. They don't really belong to a group. The first one is bupropion, which goes by the brand name of Wellbutrin. This medication increases the level of dopamine in our brains. So it acts a little bit differently than the selective serotonin reuptake inhibitors and the ones that increase norepinephrine and serotonin. This one really acts on dopamine. It also does have some slight effects with serotonin and norepinephrine, but mainly it increases dopamine. And an interesting side note is that bupropion is the medication that is in Zyban, which helps us quit smoking. And that's because when we smoke, dopamine is released. And so this medication acts on dopamine, increasing it. So that's why it's effective for smoking cessation. It does have side effects as well, though. It tends to cause quite a bit of nausea, I find, when patients start it. So taking it with food is a good idea. Nausea, vomiting. It also causes a little bit more agitation and insomnia when patients first start it. So for the first few weeks when a patient starts a medication like this, it's important to stress to them that, they might feel a little bit more agitated, which is not what we want, for the first, say, 2 weeks or month when they use it. But after that, if they can get over those first couple of weeks, then they'll start to feel better and more normal, like their normal selves. It's just those first couple weeks that they might experience a little bit more agitation. This medication can also increase your risk of seizures. So if you're a patient that has a seizure disorder, we likely wouldn't use this medication in you. Also, if you were to combine it with benzodiazepines, which is another class of drugs we'll discuss, or with too much alcohol, that could increase the risk of seizures. Same with using this medication in a patient that has an eating disorder, such as anorexia or bulimia. So there are some types of patients that we wouldn't use this medication in. The next drug is mirtazapine, also goes by the brand name of Remeron. This medication acts mainly with serotonin and norepinephrine, and it is often used as a sleep agent as well, because one of the side effects is drowsiness with it. It causes quite a bit of drowsiness. So if we see like mirtazapine at 15 milligrams, it might be used on its own to help with depression. It might be used on its own to help a patient sleep, or it might be used in combination with another agent in a patient that might be suffering from depression as well as a really bad sleeping problem, because some depressed patients also have insomnia very, very severely. So it can be used in many different ways. It does have a fairly negative side effect in that it causes quite a bit of weight gain. Patients find that they will have an increased appetite and they will gain weight on it. Also causes a bit of constipation and dry mouth. And the next one is trazodone, and it is kind of like mirtazapine in that it causes quite a bit of sedation as well, or drowsiness. So it can be used in patients that are having difficulty sleeping, as well as patients that are depressed and maybe that are having difficulty sleeping as well. It has some other side effects, such as dry mouth, orthostasis, and something called priapism, which is when a patient that is male that would have a sustained erection for a long period of time. And it's actually a neurological disorder that they would need to have medical treatment. So that is all for the antidepressants. Now we move on to a class of drugs called stimulants that are used to treat ADHD, or attention deficit disorder. The main class of, or the main medication used in ADHD is methylphenidate. It's formulated very many different ways. So you might see Ritalin, which is the brand name of methylphenidate. You might see Ritalin as an immediate release tablet or as a slow release tablet, so an SR tablet. Concerta, which is another form of Ritalin, is formulated in a very waxy kind of capsule tablet that's very hard to abuse, and it allows sustained release of the medication throughout the day, so you only have to dose it once a day. Bifenton is another form of methylphenidate. It's in a capsular form. So methylphenidate is one of the staple medications for treating ADHD, and it comes in so many different forms. Dextroamphetamine, also known as Dexedrine, it's a black and orange capsule. It is another stimulant that is used for ADHD, as well as Adderall. And Adderall is a mixed amphetamine salt. So there's many different types of amphetamine salts, and it's just a mixture of all those salts together in one capsule. It's not as common for treating ADHD. I don't see it as frequently. So stimulants work by increasing dopamine levels in our brain, and it allows the patient to focus better on tasks at hand. It makes them less hyperactive, and they're able to, stay at school better, focus at tasks better, and just function a lot better. They do have a lot of side effects though, and the biggest ones I would say would be a decrease in appetite, difficulty sleeping, and potential headache. Often those are 3 common side effects that patients will experience when they start a stimulant, and it could last for a few days up to a month. If it persists for a very long time though, I would say if the patient is still experiencing, say, headaches after a month, they might want to try switching to a medication, because nobody would want to experience headaches on a prolonged basis because of a medication. Sometimes stimulants or different formulations of a stimulant just is not right for a certain patient. So if a patient were ever to experience a psychotic reaction where they were maybe hallucinating or having delusions while on it, or if they were to just have a total personality change, like we call zombie-like effects, then I would suggest that they go to their physician and reevaluate and maybe try a new one. And stimulants are easy to overdose on as well, so you only want to take what the doctor prescribes. If a patient were to take too much, they could overdose. They might have glassy eyes in this case. They might be very hyperactive. They might have heart problems like a racing heart. So those are all signs that you might be getting too much of a dose. And lately I have found that a lot of patients are being switched from methylphenidate to other medications due to the increased heart rate that they can get from it and increased blood pressure. So other agents used in ADHD, one is Strattera, also known as atomoxetine. This medication increases only norepinephrine in our brain, and because it's not acting on dopamine, which is responsible for our reward pathway in our brain, there's less risk of abuse with it. So it does increase norepinephrine, it does help with ADHD symptoms, however there still are side effects. Headaches are common, sometimes patients get a bit of a runny nose while on it. Nausea is possible, vomiting, decreased appetite, increased heart rate and blood pressure. So some of those side effects do carry over to Strattera, even though it's not a typical stimulant. Clonidine is another medication that I find to be used quite a bit in patients that have ADHD or other mixed diagnoses. It's an old medication. It was originally used to treat hypertension, so it will lower your blood pressure. So if a patient's on clonidine and they notice that they're dizzy or they're tired while they first start it, that's because their blood pressure is likely being lowered, even though we're not using it for that purpose. So they should be aware of that, and they should just take extra time getting up from lying down, because that is a prime example where patients could become really dizzy and faint. It also causes some dry mouth. It could even potentially increase the risk of depression if you were to use it over a long period of time. It's kind of inconclusive as to whether it does cause depression or not, but it's something to watch out for. And the main reason that patients do use it is because it's very sedating. And so if you have an aggressive patient or a patient that's very hyperactive at bedtime, we often see it dosed at nighttime to help settle them down. So that is all about the medications used for treating ADHD. Is there any questions so far? No? Okay. So the next class of medications we're talking about are mood stabilizers, and they're often used to treat bipolar disorder. And bipolar disorder is a very complex disorder, and it's quite hard to diagnose because patients will either be in a manic phase where their mood is very elevated, they might even be agitated, or they can swing to a depressed phase. So bipolar patients can experience either of those. They can even experience symptoms of mania and depression at the same time. It's possible. So it's very hard to diagnose, and it's fairly difficult to treat as well. The first medication that is basically the staple for treating acute mania and even maintenance dosing to prevent a manic episode is lithium. It's formulated as a salt, so lithium carbonate. And there are two types of patients that we generally do not want to use this medication in. One is if a patient is in renal failure, and that is because it is a salt. 80 to 100% of this drug is basically cleared through our kidneys. So if a patient is having really poor kidney function, then they can't really use this medication, or we don't want to, because it's not going to be cleared from our bodies and it could become toxic very, very quickly. The second type of patient is a patient that would be pregnant in their first trimester. It is teratogenic, meaning it would cause harm to an unborn fetus. So we don't want to use it in first trimester pregnancy when all the development is going on. Saying that, it probably still is, because if you have a patient that suffers greatly from bipolar disorder, it's likely going to cause more harm to the fetus if the mother was not on medication than using medication. So it's kind of a balancing act. But if possible, we'd probably try to switch her to something else rather than keeping her on lithium. So it is one of the best medications for bipolar disorder, but it has a lot of negative side effects. Stomach upset, nausea, they're huge when patients first start them. So it's really important to take it with food. Because it is a salt, it can increase your thirst, meaning polydipsia, that's an increased thirst. It can also increase the amount that you have to use the washroom, so polyuria. It can cause dry mouth. Patients can even get a hand tremor when they first start it. As long as it's a minor tremor, it would probably be all right, or the doctor would keep them on it. But if it were to be a coarse tremor, that could be a sign of toxicity. So like I said, it's a fine line with this medication as to a therapeutic dose and a toxic dose. It causes leukocytosis, which is an increase in white blood cells. So I have seen Dr. Hussein prescribe medication if their white blood cells are going too low due to other medications, such as clozapine. It can decrease our white blood cells. Well, this medication can increase white blood cells. So sometimes I've seen him add lithium to counter the effect, because it will increase the white blood cells. As well as it can cause hypothyroidism. So if a patient is on lithium for many years, they might also have to take thyroid medication. And it can also cause rashes as well as acne and alopecia, which is a loss of hair. Like I said, it is highly toxic if you take too much. Some signs of toxicity would be very, very, very drowsy, confusion. If the patient were to seizure, vomit, those would all be signs of an overdose. Lithium is monitored, like there are blood tests that you can do to monitor the level that it is in our body. And so often when a patient starts it, they have a blood test roughly 3 days later just to make sure that they're at a good dose. Some other mood stabilizers that we have, valproic acid is a common one, and it's used very frequently. And it can be formulated as divalproex, which is an enteric-coated tablet, and that helps avoid some of the stomach problems that patients might experience when starting it. It does have side effects as well. Weight gain is quite common, sedation, thrombocytopenia is common too. That's when our platelets go to a lower level, so they can detect that through blood tests. This medication can cause polycystic ovarian syndrome and menstrual irregularities in women. It can also cause hair loss and hyperammonia, so ammonia levels to increase in our body. It's also metabolized through the liver, and it can increase liver enzymes, indicating potential liver damage. So the doctors do blood tests to monitor all that while on this medication. The next one is lamotrigine. This is a medication that is often used in bipolar patients that suffer from the depressive symptoms, whereas valproic acid and lithium are often used in for treating manic symptoms as well as maintaining a patient at a proper level or mood, I guess. Lamotrigine is often used in depressive symptoms of bipolar. You don't really see a lot of antidepressants like, say, Paxil in patients that are bipolar, and the reason why we do that, or we don't do that, is because if you put a patient that is bipolar on an antidepressant, it could push them into the manic phase. So they found that lamotrigine is pretty good for helping depressive symptoms and not pushing patient to a manic phase. Lamotrigine has side effects as well, dizziness, diplopia, which is a double vision, nausea, vomiting. A rash is pretty common too for patients to develop a rash while on this medication. About 10 to 15% of patients can have a rash develop, and of that 15%, roughly 1% could have a serious allergic reaction which develops in the form of a rash. So if you do develop a rash while on lamotrigine, it might be a good idea just to check it out to make sure it's not the serious allergic reaction. Carbamazepine is another mood stabilizer. It's kind of more as a second-line therapy, but it is used quite frequently. It has side effects, and they're kind of the same ones as the other ones: dizziness, drowsiness. They're common throughout all of these medications. Can cause blurred vision. It can also cause something called nystagmus, which is when your pupils move back and forth really, really quickly. And if that were to happen, it could be a sign that maybe the patient is getting too much. So you'd want to maybe get it checked out. The doctor would run blood tests and determine if the dose is maybe too much for the patient. Nausea, vomiting is common, so taking with food is a good idea. Some patients get diarrhea when they start it. Rash, thrombocytopenia, again, which is low platelet levels. Hyponatremia can occur, which is low sodium levels. So just another test that the doctor is going to run to make sure your sodium levels are accurate. And it can also cause weight gain as well. Topiramate is another medication that we're seeing more frequently be used as a mood stabilizer or as treatment that you add on if the other medication isn't working real well for a patient. It's generally used as an anti-epileptic medication, as with all of these medications can be used in epilepsy, but it is being used more frequently as a mood stabilizer. With this medication, it actually usually causes a weight loss in patients. So that's something to monitor just to make sure that patients aren't losing too much weight while on it. It can also cause some cognitive impairment or kind of foggy thinking, as well as kidney stones is kind of a negative side effect for this one. They're not very pleasant, and so if a patient does develop them, they would have to get medical treatment to help pass the stones. It can also cause sedation, tremor, dyspepsia, which is an upset stomach, and acute myopia. So that is basically a condition of the eye. So if a patient develops changes in their vision while on this medication, you should probably get it checked out with an optometrist. And the next class of drugs are antipsychotics. They're used to treat schizophrenia, and they're also used, though, for many other indications as well. Lots of antipsychotics, specifically the atypicals, are being used as mood stabilizers. So just because a patient is on one of them doesn't mean that they have schizophrenia. But these medications are traditionally used for treatment of schizophrenia. In schizophrenia, patients have elevated dopamine levels, and that's why they're experiencing hallucinations, thoughts of that are not real, delusions. So all antipsychotics block dopamine, and that's how we help treat the condition. So typical antipsychotics were developed first. They're fairly old medications. And in this class of medications, we have chlorpromazine, trifluperazine, perfenazine, fluphenazine, haloperidol, and loxapine. These medications have a lot of negative side effects, as do the other class that I'm going to talk to you about right away. But the side effects of typical antipsychotics tend to be more debilitating to the patient and interfering in their everyday life, whereas the atypical antipsychotics, their side effects tend to be more manageable, I guess. So for side effects, as you can see, it's a very long list. They cause sedation, blurred vision, constipation, dry mouth, urinary retention, and they can cause something called extrapyramidal syndrome. So there's an area of our brain that is responsible for involuntary muscle movement, and these medications can affect that center and cause patients to have weird muscle movements that they're not really controlling. So for example, they might have really bad muscle rigidity in that they can't really move their muscles. They might appear really stiff. They might have a hard time initiating movement too. They can have motor restlessness, so they might be shaking all the time. They can even get something called tardive dyskinesia, and that's where your tongue moves uncontrollably. So I've seen it before in elderly patients. I haven't seen it a lot in younger patients because I think doctors are more aware of these negative side effects, and if patients start to show slightest signs of it, they take them off of it right away, because these side effects, once they're there, they can be permanent and they're just not pleasant. So along with those weird muscle movement side effects, they also can lower your seizure threshold. They can cause weight gain. At really high doses, they can even cause patients to lactate when they're not pregnant. And I think it's even possible for even men to potentially lactate on these medications at high doses, but those are very, very rare side effects. And they can cause photosensitivity of your skin to the sun. So a lot of negative side effects on these medications. So the next class of antipsychotics are the atypical antipsychotics. And like I said, they do have a lot of side effects, but they're not so debilitating to the patient. Instead, they cause weight gain. They can cause diabetes in patients. So increased blood sugar, which is not a nice side effect, but it doesn't seem to interfere in a patient's life as much, in that at least they can still walk around easily without assistance. They can cause high cholesterol levels. So often these patients that are on atypical antipsychotics end up having more cardiovascular conditions in the long run because of the side effects of the antipsychotic. They can cause sedation as well, dry mouth, constipation, upset stomach. Those are all common side effects as well. So in this class, we have clozapine, which goes by the brand name of Clozaril, olanzapine, which is known as Zyprexa, quetiapine, which is Seroquel, risperidone, which is also the brand name of Risperdal, aripiprazole, sorpranolone, and paliperidone. Out of this class of medications, Clozaril has something really unique about it. It can lower our white blood cells, like I said before, and so it requires routine blood work. So if you're dealing with youth that are on Clozaril, you'll quickly learn that they go for routine blood work, whether it be weekly, twice a week, or once a month. And if the levels drop in their white blood cells, then they might go from, saying, a 2-week patient in which they can have a 14-day supply of medication to a 1-week patient in which they can only have 7 days at a time, because they require that blood work to monitor white blood cells. Clozapine also has it's more likely to cause excess salivation in patients. So you might notice that if a patient is on Clozaril, they might have a large amount of saliva, or they might kind of drool even. That's quite common. Olanzapine is quite a bit, it's very constipating. Patients that start it find they have quite a bit of constipation when they start it. And Seroquel is often used as a sleep agent too. It can be dosed very high, up to, I believe, 600 or 800 milligrams a day. It can also be dosed very low, 25 milligrams. And when we see it at 25 milligrams, it's often used, to help patients sleep, or to help kind of augment the effects of other medications that they might be on. So the last class of drugs that we're going to talk about are benzodiazepines. And there's a whole bunch of benzodiazepines that are on the market. I've only listed 3 here because they tend to be the more common ones: alprazolam, lorazepam, and clonazepam. But like I said, there's tons of other ones like diazepam, which goes by the brand name of Valium, bromazepam. There's just tons of them out there. So these medications are used for several different indications. They can be used as sleep agents to help a patient sleep. They can be used in aggressive patients for a short period of time where a patient might be experiencing quite a bit of aggression and they just need to calm them down quickly. They can be used in seizure disorders. They can be used as medications to help treat anxiety. So they do have a few side effects. Often drowsiness and dizziness are the most common. They can also cause patients to have decreased concentration or kind of foggy thinking while on it. And they can cause something called retrograde amnesia, and that just means that when you take the pill, you might be awake and doing something, and then when the medication is kind of out of our system, you forget what you've done. So that is common. Specifically with alprazolam, I think it's kind of worse for causing that. At least that's what my professor had once told me. He had a personal experience with that. And these medications can also cause dependence, meaning if you take them on a regular basis, and maybe you're supposed to use it only when needed for a bout of anxiety, then you'll continue to use it on a regular basis and you'll want to. If you were to discontinue them, you could go through withdrawal rapid. Like if you discontinue them immediately, you could go with withdrawal if you were using them on a regular basis. Pardon me. So if the directions are, twice a day when needed, you only want to use it when needed. So that is everything on medications. Now this is going to be about the policy. So all medications must be authorized by a licensed physician, and medications will fall under two classes. There's medications for physical health, like say a patient requires an antibiotic because they have a chest infection. You can take them to a doctor and get a medication initiated immediately. You don't need prior approval or anything like that. However, if an agency worker is thinking that a patient maybe would benefit from a medication that is for mental health purposes, it requires consent from the legal guardian and from the youth themselves and the referring agency worker. So the doctor will discuss what the medication is used for in an appointment, and they'll go over side effects, and then it's kind of a joint decision whether the patient is going to sign and allow them to start this medication. And it is usually given as written consent whether a mental health medication may be administered. So all staff must receive training from a licensed pharmacist or nurse in order to dispense medication to youth, and that is what you're doing today. Training must be completed prior to giving medication or administering it, and it should be renewed every 3 years, and the program manager is responsible for supervising and enforcing the policies and procedures. Okay, so prescription medications. For prescription medication, the staff must take the written prescription to a designated pharmacy, and that is the Victoria Square Pharmacy for here in Prince Albert. Each agency, whether it be based out of Saskatoon, PA, or North Battleford, uses the one pharmacy, and that's pretty important because with our store, at least, I'm pretty much the only pharmacist that deals with it. The other pharmacists will fill in, but I kind of get to know the medications, what each patient is on, and I'm able to identify a drug interaction readily. If we take a patient to my pharmacy one time, a different pharmacy the next, medications can get started and interactions can occur. Medications might be started in one pharmacy, and if I'm not aware of it, I maybe think that a patient is still on this other medication. So it's really hard to have a continuum of care when a whole bunch of people and a whole bunch of pharmacies are involved. But saying that, if you need to start a medication immediately, I'm sure that starting it at another pharmacy and then bringing it to our attention would also be fine. For example, if you need to start something on the weekend and we're not open, if you take it to another pharmacy, that's fine. Just make us aware of the change, and then we know what's going on as well. So the staff members, when filling a medication, they should really ask for copies of the prescription. So whoever takes the prescription and just ask if you could get a photocopy, we photocopy it for you and write copy on it. And then that copy goes into the logbook for that youth. And you should probably ask for drug information sheets when a new prescription has been started. And that just discusses the side effects and the use of the medication. So we can print those off as well. In Once the medication is obtained, it is then locked in the designated locked area, and the MAR that the pharmacy provides you with is then put in the medication logbook. So I know our pharmacy prints off a little sheet, and it just has the patient name, all their medications, and I think it has days 1 to 30 on it, so you can sign it when giving it out. And that's just put in that's called the MAR, and it's put in the use logbook. Staff are supposed to write notes in the logbook to alert other staff when the youth has been prescribed a new medication or when there's been a medication change. And I just have there that it's important to notify the pharmacy too. The medication log sheet, or the MAR, provides the following information for you. It has the youth's name on it, the medication name, the prescription number, the frequency of medication, so if it's dosed twice a day or 3 times a day, and the dosage, whether it's a 25 milligram tablet or say 50 milligram. When administering the medications, staff are responsible to administer the right medication at the right dose to the right resident at the right time using the right route. So that's a lot of things to remember, but if you look at the MAR and you thoroughly read the information and you can repeat it as you're administering it to the patient, and if you look on the medication package and make sure that it's matching up to what the MAR says, the room for error is quite low. It's unlikely that there will be an error. But still, it's really important to always double check things. Staff are supposed to supervise the resident and observe and assess and monitor to ensure the medication is taken completely. It is important to make sure that the medication is not being saved, stored, or given to another youth. It's important to administer the medication in a confidential manner. You don't want to be shouting out the medication that one youth is on for everybody to hear, because it's nobody else's business but that youth's and yours. The staff must ensure that the medications are locked up to prevent youth from accessing them inappropriately, and staff should try really hard to administer it at the right time. It can be hard depending on how many times you have to dose a medication in a day, but it is important to try to give it at the right time. If the medication is late by over an hour, you should call the pharmacy and we can direct you further. It might be okay to give it, it might not be, depending on the dose and how soon the next dose is. So if you've missed it by over an hour, just give us a call and we can advise you how to proceed. So when you're administering medication, there's also a component of documentation that you have to do. Staff are responsible to initial the MAR each time he or she administers a medication to the youth, whether it be prescription or non-prescription. Staff must provide teachers with 1 week's supply of medication and a school MAR or log if the youth is required to take medication at school. Night staff review the medication logs to identify med errors and will report the errors to the program manager. And the program manager reviews and initials the logs on a weekly basis. So staff must identify situations that require consultation with a program manager, physician, or pharmacist. Staff must be familiar with the medication and possible side effects, and be able to identify those side effects or potential drug interactions. So if you notice something that is not normal when you're administering the medication, say you take a youth and they just started Epival or Divalproex, and they take it and they're complaining to you an hour later about how upset their stomach is and they feel really nauseated. That would be something that you could maybe identify as a drug adverse effect, and you'd want to document it and then maybe talk to the program manager or even call the pharmacy, and then we would probably advise you, well, make sure the next time that they take it with food, because that might help decrease nausea. So that's kind of something that you would probably be able to identify as a drug adverse effect. As far as drug interactions go, if the pharmacy is the same pharmacy, we should help you identify drug interactions. Hopefully we wouldn't dispense it if there was a serious one, because we generally know about that before it even goes out to the patient. Staff must seek medical assistance in responding to adverse effects. You must report any concerns to the program manager immediately. If you are trying to identify a drug-related problem, there are some areas that you can go for help. You can phone the Sask Health Information Line. It's open 24/7, and that's the phone number there. Or you can call our pharmacy and we can help you out. Any adverse effect or drug interaction will be recorded by staff on a critical incident report. Staff should consult the pharmacist, physician, or health line for advice with regards to administering medication when the youth return to the program after an unauthorized or non-supervised leave where alcohol or illicit drugs may have been ingested. So if a patient runs away from you guys and when they come back you know that they're intoxicated, you should give us a call and see if you should administer the medication. You should take into account the number of days or hours that the youth has been absent. So I mean, if they said to you, yeah, I was really drunk 4 days ago or something like that when they were gone, but now they're back, then chances are it's okay because alcohol would be out of their system 4 days later. But if it's kind of an immediate situation where you know that they're intoxicated now and you have to administer their meds right now, then you'd want to get advice. So one thing to remember is that youth do have the right to refuse medication. You should be encouraging them, though, to use the medication regularly, remind them of the benefits of it. You should document refusals on the critical incident report and determine why the youth isn't taking the medication. So maybe they have a really upset stomach all the time from it, and so you would want to document that and then we would reassess later. Maybe they just need to be switched to something else. If the youth repeatedly refuses the medication, an appointment should be made with the physician and the legal guardian, and the youth will be notified. So often medication goes lost or missed. Document missed medication resulting from the youth's own actions in the medication log book. So say the youth takes it from you and goes to swallow it, but then decides to take it out and maybe throw it on the floor or something and step on it. I don't know if that ever happens, but that would be documented in the MAR. However, if you're supposed to document missed medication resulting from staff error as a critical incident report. So say you are handling it at this moment and you drop it on the floor or something, then that is a critical incident report thing that you have to document that way. However, in the case of anybody, say losing the medication, bring it to the pharmacy's attention right away. Just because we can correct the mistake right away when it happens. I know that at times we've dispensed medications and at the very end of the month the patients have run out or maybe they were lost at the end. The sooner you find out that a medication is lost or has been, damaged or something, tell the pharmacy and then we can get you a new supply. Sometimes I'm sure it's pharmacy's fault. Could be that one of our medication packages didn't spit out the right day or something and maybe we didn't ever dispense it to you. But the sooner that you notice that there is something wrong, make sure to tell us and then we can correct it as soon as we can. So disposal of medication. Some medication that is never used or has been discontinued and something else has been started should be returned to the pharmacy. You should record return medication in the logbook and you probably will have to sign that you're returning it. So youth admitted to the program that already have medications, they're a little bit trickier, I guess, or there's more steps when they are coming into the program if they're already started on a medication. So the program manager or caseworker will take possession of the medication during the admission meeting and they will contact the issuing pharmacy to confirm the following information. So if a patient is coming into your program, the program manager will look at all the medications that they have, like all the bottles. They will call that pharmacy that dispensed them and just confirm that they're still on all those medications, that the doses are right, that the route of administration is right, and they'll also probably determine when was the last time they had taken a dose. So once they find out all that information, the program manager will then verify from the referring worker or the legal guardian the purpose of the medication, the date and time that it was last taken, when the next dose is to be administered, and any side effects or adverse reactions that they should know about. The caseworker or program manager will then contact the prescribing physician, verify the information, and then ask that a new prescription be sent to our pharmacy so we can dispense it for you guys, because we dispense them in special packages, whereas other pharmacies might not. This is just an example of what our packages look like. I don't know, have you guys seen them before? Yeah. So they package them that way. All the information is on them. They have patient's name, the medication name, the dose, how many the patient's taken at a time, and the time that it's to be administered. So there are some types of medications that we don't have to package for patients and that they can administer on their own. These include birth control tablets, creams for rashes like say hydrocortisone cream, vaginal suppositories, bronchodilators like salbutamol if a patient is asthmatic, epinephrine pens, and medicated shampoos like Head and Shoulders or something like that. Staff are to monitor and ensure the regular use of these agents, and you could even record it if you wish or if the patient wishes. Self-administered medications must be approved by the program manager first, though. So if you have a youth coming to you and saying, I want to go on birth control, it has to be approved first.
And they will include daily recording.
Yeah, okay, it is. You know, we could always package those too if that becomes a problem. Just to keep that in the back of your mind, we can potentially package birth control. So non-prescription medications are kept in the locked medication cabinet, and logs for each medication are maintained. So there will be like a piece of paper saying Tylenol, and you just have to write all that information in, like the use name, the dose that you're giving, and your initials. Injected medications. So there are a few medications that are injected, whether it be Depo-Provera or some antipsychotics, they can be injected as well. Regardless, medication is to be injected by a nurse or physician, except for insulin and EpiPens. So if a patient requires an EpiPen, then either the patient or the caregiver will administer that if they need it. Same with insulin. But I don't think we have that problem with any of our youth right now. Home visits. So the staff member planning the visit is responsible to provide the parent or legal guardian with the right quantity of medication for the duration of stay, the MAR, the medication for administration on home visits or placement change form, any written instructions, important side effects that they should know about, and you're also going to give them, the log or the MAR. And it's important to make sure you get that log back when the youth returns. So if the patient is going to be temporarily gone for a while, or if they're getting discharged, the program manager or caseworker must ensure that the youth's remaining medication, and this should be a minimum of 7 days, and the medication log be transferred to the next caregiver. So just another recap of everything that must be given. The patient medication information sheets, the medication for administration on home visits or placement change form, instructions for giving it, instructions or information on side effects. You should also give the pharmacy contact number and the name, phone number, and address of prescribing physician. And so the last little bit of this presentation just talks about missing doses. Back to the policy stating that medication should really be given at the right time, and if not, you should ask for advice. It is important to follow those rules just because dosing intervals are not just trivial numbers. They are based on studies to make sure that the drug is going to work effectively. And for example, amoxicillin is one of the easiest examples to understand it. Amoxil is basically always dosed 3 times a day. If not, it's maybe dosed 4 times a day, but generally always 3 times a day. And that's because when the drug is studied, we know that it requires 3 doses that are spaced evenly apart to keep the medication at an appropriate level to kill the bacteria that is causing the infection. If you were to dose it twice a day, your blood levels would fall to a point that is too low and the bacterial infection would not be treated. And this goes with all medications, really. They've been studied, and we need to dose them at the certain times because that is going to guarantee that we're going to have an effective response. If you dose too frequently, you could have the other problem in that you're getting too much drug in your body, and then the patient could experience toxicity. So to be effective, drug levels must be within the therapeutic window, and that's just what this shows. This medication, or for this diagram, whatever it is supposed to be dosed twice a day. So the patient takes the capsule, the drug levels peak in our blood, and then they fall. So if you were to dose too soon, if you were, say, to dose like in 4 hours, you would get more blood level or more drug, and the blood levels would go even higher, and the patient could maybe get symptoms of toxicity. And if you were to dose maybe once a day, you would see that the drug levels fall too low and they wouldn't be getting effect at all. So it's important to try to keep them at the right times. And just there's this last slide, which is the review slide. Just remember that the patient medication or the patient medical profile needs to contain all these things: the MAR, the copies of prescriptions and drug information sheets, as well as written notes regarding whether a medication has been stopped or added or any adverse effects. And when administering the medication, you should really state the name of the use, the medication name, and the total dose administered. And just some other tips. If you're ever unsure about something, ask. It's really important that you do. Too much documentation is always better than too little. And always be aware of allergies, and confidentiality is always very important. And that's it.
Thank you very much, Sarah.
Thank you.